great pleasure to invite Dr. Nitesh Singhal to the stadium. We were very foolish and let him go from the Queensland Children's Hospital, where he is now at Westmead, and he has a special interest in neurointensive care, and he's going to talk to us today on the contemporary approach to status epilepticus.
Thanks, Liz. I would like to thank the organizing committee for having me here. We'll be talking about the contemporary approach to status epilepticus. Before I start, I would just want to highlight how big is the problem. As you all know, status epilepticus is the most common pediatric neurological emergency. Incidence is anywhere between 17 to 23 episodes per 100,000 children per year. Of this, around 10 to 25% of the patients progress to refractory status epilepticus and has significant morbidity and mortality. So it's a big problem, and it forms a big component of our ICU population. So in the next 15 to 20 minutes, I will try to talk about what are the recent changes, what are the current recommendations, what is the evidence behind those recommendations, what is actually happening in current clinical practice, and is there any relation to time to treatment and the outcome of this patient? So in the last few years, these two papers has come. The top one, in 2012, the Neurocritical Care Society has come up with the guidelines for the evaluation and management of this patient. And subsequently, in 2016, the American Epilepsy Society published the guidelines for both children and adults. And both the guidelines are probably same. And what they have suggested in terms of the changes. First, in terms of how do you define. So as you know, traditionally, status epilepticus is defined as anything that lasts for more than 30 minutes. What this guidelines are suggesting is status epilepticus should be defined as 5 minutes or more of continuous clinical or electrographic seizure activity or recurrent seizure activity without recovery between seizures. And the main rationale for cutting down the time from 30 minutes to 5 minutes were two. The one, there is more and more upcoming evidence that the prolonged the seizures are, the more difficult to control them in terms of pharmacoresistance. There occurs some pathophysiological changes at the receptor levels, and it's more and more difficult to control beyond 5 minutes. And secondly, there is some more and more data coming that the longer the seizures are, the more the harmful effects on the brain. And in terms of the refractory status epilepticus, again, there was a lot of confusion previously. What's the timeline? What should be the duration when you label them as refractory status? To make things simple, if a patient has a dose of benzodiazepine and a second appropriate anti-seizure medication, and if he is still having seizures, then he will be labeled as in refractory status epilepticus. So let's see what this society are recommending in terms of the treatment. So as you can see on the left, on the flowchart, on this flowchart, they have summarized their recommendations, and they are divided in terms of the timeline, as you can see on the left. Let's try to see it in a little bit more detail. So what they are saying is in the initial 5 minutes, that will be the stabilization phase. You assess the patient, do your regular ABC, try to get an IV access, try to do the electrolytes, and make sure that they are not hypoglycemic. Progress to the next step, that's the initial therapy phase within the first 5 to 20 minutes. So what they are recommending is that the patient should have an initial dose of benzodiazepine as soon as possible after 5 minutes. In terms of which benzodiazepine the patient should receive, it can be either midazolam, lorazepam, or diazepam. I will come to the evidence a little bit later, but all three of them are equally effective. If the patient is still seizing after the initial dose of benzodiazepine, he should be escalated to a second anti-epileptic drug. And again, the evidence is much less here. The recommendation is patient can either have phenytoin, valproic acid, or levetiracetam. Progressing further, as per the definition, now the patient is in refractory status epilepticus. And as you can clearly see, they have mentioned there is no clear evidence to guide therapy in this phase. The choices include the patient can either have a repeat second-line therapy, or the patient should be started on anesthetic doses of either thiopentol, midazolam, pentobarbital, or propofol. Some of the other recommendations are the treatment should be guided by continuous EEG monitoring, especially in the patients who are having refractory status. And the reason behind that is there's a lot of studies which have suggested that a large proportion of these patients are in non-convulsive status. And unless and until you put them on EEG, there is no way you can diagnose that. So the goal of the treatment is termination of not only clinical but also electrographic seizure activity as early as possible. And the other recommendation is if they are started on anesthetic doses of infusions, they should be seizure-free electrographically for 24 to 48 hours before we start slowly withdrawing the infusions. So let's see some of the evidence with regards to the choice of anti-epileptic drugs which they are recommending. So the best evidence is for the first-line treatment with regards to the benzodiazepines. And all three of them are equally effective. There's a large trial in children and adult rampart trial, RCT comparing IM midazolam versus IV lorazepam. Both of them were found to be equally effective with regards to the efficacy and same side effects. And there was another trial comparing lorazepam versus diazepam for in pediatrics, and again equal efficacy. So the summary is whatever benzodiazepine is available should be used, and all of them have equal efficacy. Coming to the second-line medications, the evidence is less and less. So this recent paper, they have done a meta-analysis of published studies looking into the 5 anti-epileptic drugs for the treatment of benzodiazepine-resistant convulsive status epilepticus. What they have found out is probably the phenytoin is probably the least effective in controlling the seizures where benzodiazepine has not done much. Phenytoin has a 50% efficacy as compared to the valproate, which is around 76%. Having said that, the quality of the studies in this is very poor. There were no randomized controlled trials and a lot of heterogeneity. So what should we do? So the good news is there are more and more upcoming trials which can help us which second-line agent should we choose. The top one, the concept trial. Again, big multi-center randomized controlled trial comparing levetiracetam versus phenytoin as a second-line agent. The results are not yet published, but I believe what this has shown is that both are equally effective and the side effects profile is again the same. Similar trial, ongoing trial, Eclipse, comparing levetiracetam versus phenytoin. And then the third one, ASSET trial, they are comparing valproate, levetiracetam, and phenytoin as a second-line agent in both children and adults. So hopefully in next few years, we'll have some more answers with regards to the choice of second anti-epileptic agent. Going further down, in terms of choosing the third-line agent, literally there is no evidence what to choose. So basically coming to the pharmacological coma, the two most commonly agents that are being used are midazolam or thiopentone. As I have said, there is no evidence that one is better than the other. However, midazolam is being used most commonly, and the likely reason is because midazolam has less adverse side effects. Just want to highlight quickly about the midazolam infusion. It looks like on the reading through the literature, there is a lot of knowledge gap in terms of how to use the midazolam infusion. So once the patient gets started on midazolam infusion after having a bolus dose, the key thing is someone should be at the bedside. And if the patient is still having seizures, the patient should get a bolus, and the midazolam infusion should be escalated rapidly, should be increased by 2 mg per kilo per minute every 5 minutes. And the dose range that has been used in the literature is very high, up to 30 to 35 mg per kilo per minute. And if there is no response to the midazolam infusion, there should be a rapid escalation to a second agent. So within an hour or two, if there is no response, the patient should be switched to another agent. Some of the other drugs which has been used in the management of these patients, one of ketamine, there is more and more interest with the ketamine. And the rationale behind that in terms of how the pathophysiology changes as the seizures get prolonged, the NMDA receptors get upregulated. And ketamine, being a strong anti-NMDA receptor antagonist, can be a good anti-epileptic drug. So there is a big trial, randomized trial going on in Italy, where they are comparing ketamine with other, with midazolam and thiopentone, and hopefully we'll have some answers. Some of the other drugs that has been used, and I won't go into detail, is lignocaine, magnesium sulfate, propofol, and inhaled anesthetics. Other alternative therapies which have been used in the management of these patients, again, I won't go into detail, are immunomodulatory therapy. People have used ketogenic diet, therapeutic hypothermia, epilepsy surgery, and vagal nerve stimulation. So these are the recommendations. Let's see what is happening in the current clinical practice. So a few years back, a group of neurologists and epileptologists in USA came together, and they created a pediatric status epilepticus research group. And they have identified a number of hospitals in the USA who were taking care of these patients. And they are looking into what actually is happening in these hospitals and how are these patients being managed. And they are coming up with a few nice studies. So this is one of the studies from their group. And what they have looked in this study is how much time does the child has before he received any dose of antiepileptic after he started having seizure. So this was a prospective study in 9 hospitals. They enrolled around 81 patients over 2 years' time. And what they have found out is only 38% of the patients received any anti-epileptic drug before he arrived to the hospital. There was a significant delay in administration of anti-epileptic drugs. The median time for the patient to receive the first anti-epileptic was around 20 minutes after he started seizing. And the other important finding was once in the hospital, patient received repeated doses of benzodiazepines, which may not be helpful but leads to more side effects. The one important thing from this paper was there's a lot of patients who started having seizures out of hospital, which could have caused significant delay in receiving them in the anti-epileptics. So when they look at the subpopulation of the patient who started having seizures in hospital, and what they have found out is even in 25% of those patients, the median time to receive any anti-epileptic was more than 15 to 20 minutes. So subsequently, the same group looked into what's happening into the patients who are in hospital, who are in refractory status epilepticus. How much time does it take for them to get started on any sort of infusions? So the findings from them were most of those patients received median of 5 doses of anti-epileptics before they were started on any infusions. They spent prolonged time in status before they were started on midazolam infusion. And this is in hospital, so they spent around more than 2 hours having seizures before someone decided that they should be started on midazolam infusion. Timing to escalate to second anesthetics was around 24 hours. So they were still on some midazolam infusion for 24 hours and then escalated to pentobarbital. And the endpoint for the seizure termination was in 48% of the patients clinical seizures, so there was no EEG availability. So both these studies have shown that currently there is a lot of delay in the treatment of these patients, both pre-hospital and in hospital. But I guess the big question is, does it really matter? Is there an evidence which shows does it affect the outcome? Till recently, there has been some retrospective data regarding that. But again, this sorry, got stuck here.
Are you trying to get it backward? You meant to do that, Nitesh, just if everyone was awake.
So basically, I'll continue. So basically, the same group have come up with a recent study where they have looked into what happens, what's the relation with the time to treatment and the outcome in this patient. And so a study from the same group, around 218 patients from 11 hospitals. The patients were divided into 2 cohorts, whether they received benzodiazepine in the initial 10 minutes or they were delayed and received benzodiazepine after 10 minutes. The primary outcome was death during hospital admission, and the secondary outcome was need for continuous infusion for seizure termination. Not surprisingly, they find that 66% of the patients received untimely first-line treatment. But what the significant finding was, on the right, as you can see, the 7% of the patients who were dead were all have untimely treatment. And when they did multivariate analysis controlling for other factors and etiology, they found out that the adjusted odds ratio of death for patients with untimely treatment was 11. So what can be done for this? This group has nicely shown that when they implemented a quality improvement project in their unit, whether it made any change to the outcome with regards to the treatment and admission to the ICU. So what they have looked at it is, their aim was to decrease the time when the patient will get first dose of benzodiazepine. And things they have implemented was they get more and more education to the nursing staff and the nurse practitioner. They made the medications and equipment availability easy, and then medication preparation and staff availability. And what they have found out after 17 months after starting the project was they were able to show that they were able to significantly decrease the time to treat seizures from a baseline of 14 minutes to 7.5 minutes. The proportion of the patients who got transferred to the ICU after this decreased from 39% to 9%. And they were able to show that they were able to estimate around an estimate of $2.1 million of hospital charges were mitigated. So in summary, status epilepticus is a neurological emergency, as we know. The key is treatment should be started early and escalated rapidly. And I believe time to treatment is the most important modifiable factor and critical in improving the management and outcome of this patient. Probably just a last slide, as this group has suggested, it's probably now time for seizure course, like trauma course and stroke course. It's probably time for seizure course team. Once the patient comes to the AED, this team gets activated and the patient should start treatment. Thank you.
Thanks, Nitesh. That's a great summary there. Any questions?
Nitesh, I have a question.
Sure.
Let's just say this is a naive social work question, but would one of the big issues be like who actually has control of these patients, the neurologists or the ICU doctors? And, you know, is that one of the big tensions?
No, I think ICU should have a control of this patient.
Is that your total answer? Is that always the case, though? Do you really think?
So, again, I think it comes to that knowledge gap. So some of the time what happens, once the patient comes to the ICU, and depends upon what teams are involved, some of the time we leave it up to the neurology to manage this patient. But in my opinion, ideally, it's good to have the neurology opinion, and we need their services for EEG and other things. But in terms of escalation of the treatment, it should be the ICU people who should be bedside and escalating the treatment with regards to whether there needs to be started on Midazolam infusion or thiopentone infusion, and the escalation of the treatment. We don't need to give a call to neurology every 5 minutes that the patient is still having seizures. What should we do next? What should we do next? So we should be the one who should be doing those things in acute phase, and then once they go out of the ICU, obviously the neurology will follow them.
Thank you. Any other questions from the floor? Oh.
Hi, Tina Kendrick from NETS in New South Wales. We move a huge number of these children every year, and I think the problem starts well in the pre-hospital or an emergency setting where the focus seems to be on managing airway and getting a tube in rather than the delivery of a second-line seizure agent. And I think we really have a lot of work to do in that space in reminding people you can do bag mask ventilation if you need to. We can certainly oxygenate these children, but what we are not seeing is a rapid move to deliver agents to actually stop the seizures. And I know that I share the frustration of my colleagues at Sydney Children's Hospital at Randwick who have done a lot of work on this, the neurology team. So that's been our big message is you've got to stop the seizures. Don't worry about the airway just yet.
Absolutely. Yeah, so absolutely. So it comes down to what resources you have. So ideally speaking, you should have continuous EEG. But here in Australia, we are not as lucky as in Toronto, where there are fellows sitting in the night watching the EEG. So what some of the units has come up with, not in Australia, in other places, is something called as quantitative EEG. So the patient is still on continuous EEG, but the neurologist doesn't need to sit overnight and look into those EEGs. There is a pattern on the, with regards to color spectrum, which the intensivist and the nursing team can have a look. And they give you a rough idea. If the pattern goes out of what is happening over the last few hours, then there is a suspicion that can be a seizure. In that case, the nurses or the doctors can capture that and can call the neurology or can just directly escalate the treatment. So you don't need to have a neurology. So in an ideal world, you should have a neurology looking at those EEG overnight. But if you don't have, then something called as quantitative EEG will be helpful.
Can I ask you to thank Nitesh one more time for a great presentation?